mucous membranes, the nose, the mouth. It can be in in the organs of your body, which you call visceral, and this is the most lethal one. If you have it, if you're not treated, you die. And then, of course, when you treat the visceral form, you can get complications and get what we call post-calazar dermal leishmaniasis. Also difficult to treat. So I will just say that, in the interest of time, I don't know how many minutes I have. Leishmaniasis East Africa platform is an African platform that was created by DNDi and the 4 countries, Kenya, Uganda, Ethiopia, Sudan. Kenya, Uganda, Ethiopia, and Sudan, yes. And to bring everyone together, experts in leishmaniasis, to share ideas, to test these drugs that were available to see which one works for this condition. And I tell you, this is a very good partnership. It was difficult in the beginning, but now really there's true partnership here. And all for the benefit of getting treatments for patients who have leishmaniasis. And we work together with the Ministries of Health and make sure that we translate the research findings into policy. We train, LEAP platform trains also, in the beginning there was really, because the leishmaniasis is in the middle of nowhere, in very, very remote parts, say even of Kenya, in the northern part of Kenya, in West Pokot, where, the environment is harsh. And so we have to upgrade the labs, we have to train people, and to get there is really a nightmare in some countries as well. And this is where we started in the tents. No, somebody. I don't know, I'm now lost. I think the system is telling me that I need to finish. Okay. Yeah, okay, so let's move on. The training, and also we developed a data management by statistics center, which really helped us with pulling together data from Africa and making sense out of it, and deciding that after the analysis that these drugs work, and once they work, then we work with the ministry, change policy with WHO, and this was really a success. We also, communication is key in these neglected diseases, because there has to be awareness of the disease. And, we work with the media, with the digital communication, and we also provide audiovisual content stories with award-winning movies. So in brief, this is our success. I want to go into that, but it's been a very good success. And in conclusion, I just have a few words that, innovation is key. We must innovate in terms of drugs, in terms of diagnosis for neglected patients, even vaccines as well, and collaborate. And, integration is also key. Sustainable investment in research innovation is key. Money sometimes not coming very freely. Strengthening of partnerships, public-private, as I said, not-for-profit is key. Partnerships is key. And we need to engage everyone, and we have to advocate for change and influencing public policies. So we need everyone to come with us. Thank you very much.
Thank you very much. Monique, you have this passion you have for NTDs, and really happy to listen to you sometimes about it. And you're telling us that over 40% NTDs burden in Africa, and you innovate to save lives. And then one of these real innovations is what you're telling us about. Can you imagine sleeping sickness, one tablet that will cure sleeping sickness? For those of you who don't have sleeping sickness, you don't understand. But we have it in our country, and this is really good innovation. Thank you very much, Monique, for that presentation and for these novels that we have here today. Next, I will call on Professor Wilfred Bachem, and he is Professor of Biochemistry and Biotechnology and Public Health at the University of Yaoundé 1 in Cameroon. Professor Bachem, you have the floor.
Hello. I guess those who must have downloaded the program yesterday would have seen a name, Professor Kamija Fury. I certainly am not Professor Kamija. He's my friend, and I'm replacing him on this panel to talk about progress that Cameroon has made when it comes to universal health coverage, in which essentially we have gone on since yesteryears to establish different financing mechanisms to be able to assist this process. But most of what we have been financing has been out of pocket. And although, most of the government ministries are now investing in trying to finance health. We have also set up a technical committee within the Cameroon health sector to look at ways in which they can facilitate the putting in place of this universal health coverage and get everybody to buy into the situation of having to cover health. We also know that recently we made an evaluation to see what progress we had made and to see how far we had come. And we realized that there's still a lot of things, groundwork that has to be done to be able to achieve this universal health coverage. One of the things that during the analysis that came out was the fact that we needed to ensure that other diseases are actually integrated. And the non-communicable diseases was something which we felt needed to be integrated, almost from the very start. In these, we have seen that the different pathologies that are included actually have to do with preventive, but also curative. And the listing has to do with, issues about promotion, disease prevention, but also about case management. We know that the diseases or the things that have to be covered have to do with internal medicine. It also has to do with pediatrics, and it also has to do with physical injuries. It has to do also with obstetrics and gynecology, but it also has to do with issues about surgical procedures. We know that the NCDs are rising, and while the infectious diseases are declining, and it is important for us, therefore, from the very beginning, to include a comprehensive package that includes these infectious diseases. We are hoping that we'll be able to empower communities and civil society and people living with NCDs and enable policies and regulations to be able to deliver what will be sustainable services. We know that the economic burden from NCDs is becoming quite heavy on most of the developing countries, and we have to explore mixed models, given that the multi-sectoral nature of NCDs is something which we need to address from the very onset. We also need to look at ways in which we can prevent these NCDs from the risk factors and integrate primary health care as a means to achieve this shared vision of health and well-being for all. The Cameroon's health financing platform is one which needs complete revamping, and that revamping would need that even the vertical health programs that cover reproductive services and certain endemo-epidemic diseases need to be taken into consideration when we are financing this plan. The financing plan needs to be sustainable, and we thought that the out-of-pocket payments need to be reduced considerably. And for that to happen, we felt that a lot of partnerships needed to be brought on board to be able to address the SDGs, but also to look for ways in which we can raise fiscal revenue and all commodities to address all of this. And the idea, therefore, was to be able to federate the universal health coverage so that the different regions can take on this and be able to sustain this through their own levels of partnership. I guess the take-home message that I'm trying to bring forward is the fact that Cameroon has made some considerable progress, but there is still so much that needs to be done in integrating the non-communicable diseases. We need to better ensure coverage reaches the vulnerable and marginalized populations, and also to empower these populations. And we need to improve on the financial risk protection to eliminate out-of-pocket expenses at the point of delivery, and also integrate primary health care as a means to achieve the shared vision of health and well-being for all. I would like to thank you for your keen attention. Thank you.
I'd really like to thank you, Professor Mbacham. It's just at this last minute, we found out who was supposed to present this wasn't there, and he decided just to come in at least and talk about how Cameroon is doing in this area of universal health coverage. So thank you very much for stepping in at the last minute for that. And next presenter, I will call on Dr. Landry Tsage, who's the health advisor in the office to the AU and ECA UNICEF. Dr. Tsage, you have the floor.
Good afternoon. It gives me a great honor to be in this panel this afternoon. And thank you, Professor Leke, for the introduction. I'm even privileged to be sitting in this panel next to one of my hero in public health, Professor Leke. And I would like to commend you for not being among the professors who taught me medicine, but also for your contribution to building the next generation of public health leaders in Africa. So I'm requested to share some perspectives about the situation around public universal health coverage and what can we do differently to address the gaps as we strive to strengthen primary health care, not only to respond to current epidemics and pandemics, but also to prepare for the next pandemics. So my first message is that it starts and it ends at community. And because it starts and it ends at community, we need to strengthen our primary health care system as the main approach, not only ensuring that equitable access to high-impact child survival interventions and efficient delivery of health services to the population are in place. That's the precondition if we are serious about universal health coverage in Africa. When primary health care is fully funded and fully resourced, it can be the safest, most effective and efficient point of delivery of essential and comprehensive integrated health services. Unfortunately, our continent is characterized by multi-layered hazards and consequently, resilience to external shock is low. We cannot overemphasize what we went through during the COVID-19 pandemic and what we are still going through as we recover. The continent has become an environment ripe for outbreaks such as cholera, measles, while increasing the burden of drug resistance. Nearly 40 million of children are dangerously susceptible to growing measles threat because of steady decline in measles vaccination coverage. Child and newborn death from pneumonia, diarrhea, malaria, and sepsis have increased and are linked, in most cases, to drug-resistant superbugs. These health challenges are all connected to the symptoms of environments where health systems are fragile, under-resourced, and inequitable, in which poor or unpaid frontline health workers deal with multiple competing and compounding health priorities. Nowhere are these intersections seen so acutely than in zero-dose communities. So what do we call zero-dose communities? Let me start by reminding you that in 2021, in Africa, close to 18 million children received zero dose of any life-saving vaccines. And that number has increased as a result of the COVID-19 disruptions. So not only has the number of children who have not received a single vaccine increased, but entire cohorts of children in countries and communities are growing up without protection from deadly and debilitating diseases. And that's why we see outbreaks this past month of measles, outbreaks of vaccine-derived polio, outbreaks of cholera. What do we call zero-dose community? If you magnify the communities where those children are living, these are the same communities where you would find children with poorly diagnosed malaria. These are the communities where you find children with undiagnosed, neglected tropical diseases, as highlighted by the previous presenter. These are the children where you find the highest proportion of children suffering from stunting and wasting. These are the children where you find proportion of children not accessing early HIV diagnostics and long-life treatment against HIV. So, to reach the zero-dose communities, we need strong health systems. We need community engagement and participation. We need the quality in the delivery of primary health care through not only an approach which prioritizes decentralization of services, it requires a change of behavior. Zero-dose communities face multiple challenges. In some cases, these communities are also ripe with conflict, food crisis, extreme weather, events and drought, displacement, economic shocks, underscoring the need for urgent response. So let me end by emphasizing on important actions to address universal health coverage and increasing coverage of effective services. To build health systems which are stronger to shocks, current shocks and future pandemics, we need to invest in primary health care services. And the quality of our investment should be measured by how much we reach the zero-dose communities. Second, we need to put primary health care first as we discuss resource allocation at the Parliament, as we discuss prioritization of financing in the health sector. Primary health care, investing in community health system strengthening is the right thing to do. Frontline workers have shown how effective systems can be in coping with shocks like COVID-19 pandemic, when we have disruption in the routine service delivery. Frontline workers were at the forefront to ensuring continuity of services. We need to invest to provide dignified and institutionalized community health workers. Unless we strengthen our frontline to ensure continuity of services, unless we strengthen our frontline to ensure effective community surveillance, we will not be able to effectively cope with the next shock. So my last message, let's invest in our primary health care, let's institutionalize community health workers, let's provide dignified care for the frontline workers, because unless we build a resilient primary health care, we will not be able to meet the zero-dose community, the zero-dose children now. I will not be able to face the next shock. I thank you.
Good. Thank you very much, Dr. Landry Tsage. And you've brought out so much about, challenges in the health systems. And then talking about these zero-dose children, how you've insisted on it. You think 18 million? Right now, I go up to 25 million. That's a recent figure. I jump around, I go from one country to the other because of polio, just, talking about these zero-dose children all over. And I'm so glad to have heard you insist on this in this panel here, because that is something that countries really have to take up. Very important at this point, and as you say, to put primary health care really first. So thank you very much for insisting on that. And now I'll call on Dr. Christine Manyando, who's the head of the Public Health Tropical Disease Research Center in Zambia. Christine, you have the floor.
Thank you so very much, Professor, and good afternoon to the August House. I'm going to actually share the perspective of us expanding good practices and universal health coverage targets from the perspective of telling a story from a research institute, because we cannot talk about universal health coverage without talking about the efficacy and indeed the safety of whatever it is we are using to be able to treat our patients, and also whatever tools or techniques we may be using to be able to ensure that the patients or the communities that we are taking care of are being taken care of in a manner in which we know that whatever techniques or whatever it is we are using is efficacious. So I'm going to tell the story from the perspective of the Tropical Diseases Research Center, which is actually located in Zambia. This Tropical Diseases Research Center, I've actually just shown us on the picture up there as an example of a research institution in Africa doing research that should be able to inform, and also learning from some of the issues that we have gone through, which I believe could be a pathfinder for some of the other colleagues that are here, who may be also in institutions like ours, who have the responsibility to inform so that by and by, the good practices that come from the findings that we would have put in the crucible of research and proven to be able to target and ensure that we are actually having the coverage as we should have it. So I showed NCDs Central Hospital, which is actually now NCDs Teaching Hospital, and the Tropical Disease Research Center is actually premised on the 6th and 7th floor of this hospital. So it actually does happen that there is that close liaison between the curative and us, the researchers. And mind you, whatever it is we do up there, ultimately will land in this big hospital below here. So I just wanted that picture to inform us. So some of us may be aware that the Tropical Diseases Research Center actually started by the World Health Assembly minute in as far back as 1975 as a medical research institution that would do also training on behalf of WHO and in the Pan-African region as a designated center. It wasn't on its own at the time when it was actually put into effect. It was also along with two other institutions, one in Mahindo in Thailand and the other one in Brazil. So the initial mandate was just to look at the tropical diseases which were ravaging in those years, in the mid-70s, and these were malaria, schistosomiasis, trypanosomiasis, filariasis, and that was the major issue, to look at epidemiological issues and also to go on and do clinical trials. Then eventually, in the evolution of institutions and also in the plea to be able to make relevance to every institution, TDRC was made a national institute by becoming a semi-autonomous institution by the Act of Parliament in 1982. And at that time, if we recall very well, that was when HIV was beginning to become an issue in the early 80s. And so the institution went through an evolution. I'm speaking about this evolution because in the context of universal health care, in whatever business that we do, the issue is to recognize the fact that we are actually working in an environment that is evolving. So it was started, the business was tropical diseases, now the evolution went on, and we were looking at now a new epidemic altogether, and that was HIV. So as we moved on, in the first instance, it was really to be able to go through a transformation of being a center of excellence in being able to take care of tropical diseases and also to be able to underscore all matters relating to training in as far as WHO was able to give mandate to TDRC at that time. And in the second instance, it was to recognize that as we took that mandate on the African platform, we were working within a context of communities that were diverse. So the training that was initiated through how we collaborated with WHO, making us a center of excellence in that regard, we evolved over and started to look at training beyond just Zambia and looking at the mandate of Africa at large. So TDRC, the evolution was dictated by the prevailing circumstances, which epidemics always do. So in the process of having to answer to not only the national issues, but also the regional issues, continued training, Pan-African training, and continued collaboration within Africa became the premise of how we move forward. And this was to ensure that the vision does not digress, to ensure that TDRC continues to be a center of promotion of health in the African region through research and training. And in the process of doing research, training was also anchored. And the mission was really to contribute, in so doing, to socio-economic development through targeted research and product development so that together we can have effective prevention and control of diseases. And as that particular anchor of the mission and vision continued, we know that TDRC thrives on three philosophies of involvement. which become premise for us to recognize that if we are to be a part in the universal coverage and expanding the good practices, we cannot ignore that formation of collaborations is the strength that should be able to sustain inclusion of diversity. As it has been spoken and repeated several times, if you want to go fast, you go alone. But if you want to go far, you need to move even as a team or a village, so to say. So that is philosophy number one, lesson learned, which we believe that together, this is what we need to look at. Secondly, inclusion of training to build capacity and enhance efficiency. Wherever there is training, enhancement of skill, there is a way in which sustainable productivity will be achieved. This is also to really focus on the fact that without a deliberate way forward of building mentors, building the mentees, then we are not going to go anywhere in as far as expanding good practices is concerned. And thirdly, the philosophy of working in consortia. Unless we work in consortia for us to be able to share the resources, and not only share resources, synergize efforts, we may start repeating certain things that are done already by other colleagues. So the philosophies remain as the way forward. And so doing, I just show here the fact that there is the importance of being a part of consortia. And consortia is where training can be done, where skill can be enhanced. What I show there on the upper left is our reference laboratory for tuberculosis that takes care of training as well as looking at the other issues of reference laboratory for not only the northern part of Zambia, but for all who wish to have quality control taken care of. So when we look at the broad-based approach, TDRC actually looks at the diseases of public health importance as they are today. I have named some of them, or rather I have reflected some of them on the board there, but as we all know, things have evolved to the point where we are now with COVID. And being with COVID, the issue is the fact that when we are working within the premise as a research institution, an institution informing policy, an institution training and mentoring the future of how we can continue to multiply good practices, there is the issue of needing to have adaptability. There is need to be able to know that as change happens, not only with physical, but also with the pathogen, we also have to move and change with the time. When we remain behind, we fail the people for which the mandate that we'll have taken for research to be able to develop these tools and also these techniques will have not been finding its place. And further, discovering the unexpected. Within the COVID-19, we learned that within the so much that we went through, like all of us have said in this particular conference, the issue is that though there was so much pain and so much loss, we have learned that adaptability, being able to explore the unexplored, is also possible. So within this, we have evolved in technology and have been able to find a silver line of being able to work outside the domain where we are used to see physical persons, where today people can work productively at home, if not even more productively, and still be able to add to the fact that we do not leave a gap to the mandate of ensuring that universal health coverage is achieved. Productivity can be achieved without so much of physical presence. COVID has taught us, and we are glad it has taught us, but through a lot of pain. The issue of public resource for managing the epidemic in the provision of accredited accredited laboratories for diagnosis, surveillance, and quality control. We as TDRC have learned that within the COVID, we have been able to have the impact of COVID change our landscape, to be able to see the broader aspect of what we can be able to do beyond the daily business, where you diversify in what you are able to do to ensure that the provision of services, to ensure surveillance goes on, to ensure diagnosis goes on, and quality control goes on, is actually achieved. That's what COVID was able to impact us. So, what do we now say in as far as future contributions are concerned? The center continues to be available to ensure that we do as much of the collaborations as we possibly can. Because unless we poise ourselves with the strong reputation that we have had for conducting clinical trials and being available as a research and training institution to provide information and inform the curative care, that is an enabler for us to look at as a future contributor. The strong reputation in being able to do clinical trials is also to show that there is need for us to see that we will always need new missiles to be able to take care of this changing environment in which we operate, which will continue to change, whether we like it or are aware of it or not. The presence for us as TDRC to be able to have multidisciplinary scientists has for us scored a plus, because what would we produce tools and techniques for if they will not be able to produce something which the social scientists will ensure that it is enshrined in the community in the process of development, so that by the time we come to the point of effecting whichever it is that we have discovered as a working tool, then we will have carried the community along. We have underscored this severally, I think, in this conference. So we desire to ensure that the experienced number of scientists within an institution like TDRC continues to collaborate with other scientists elsewhere, so that in so doing, we continue to ensure that the barriers and the ways that will not allow us to do more in research can be taken care of. Because most of the barriers normally go to the issue of inadequate scientific staff and human resource specifically to be able to carry forward our mandates. Higher visibility and potential for funding sources can only be able to come forth if we put our hands together and collaborate and ensure that funding can be able to come, because together we can do so very much. Inadequacy in funding becomes inadequacy if there isn't cooperation and collaboration. And we believe that this is the way to go. If we can be able to mitigate our barriers by introspecting and seeing that we are the answer for us to be able to take care of the issues that will not allow us to mitigate the expansion of good practices in the universal health coverage. Thank you very much for your indulgence.
Thank you very much, Christine. You know, you have one of the oldest research institutions on the continent, and thank you for sharing with us all those good practices in research and training that you've built in TDRC in Zambia. And you talked of the adaptability, you know, that you've brought in when it is necessary. And so we thank you for sharing that with us. And last, I'm going to call on Dr. Raji Tajuddin. Did I pronounce it right? You know, I want to let this audience know that there are 3 people that were just called in to join us here. Just, you know, very few hours ago, we found out that there are 3 people that were not going to be on this panel. So Professor Mbacham, Dr. Landry, and you saw Dr. Raji coming in. It's just because they were just called in at the last minute. And I just want to say thanks to you 3 for really coming in to save us on this and for this contribution that you're making in this panel. So thank you, audience, for thanking them for us. That's really good. So now we have Dr. Raji. Thank you, and we'll listen to your presentation.
Thank you so much, Prof. And thank you, audience, for that acknowledgement. And fellow panelists, thank you for really setting the stage strongly for this particular discussion on how do we use the PHC or the universal health care, Yeah, the universal health care to really address the broader health security issues. We know that the AU Agenda 2063, that is the socio-economic blueprint for the continent, clearly identify the importance of universal health coverage. The UN social development, the UN Sustainable Development Goal also clearly articulated the importance of universal health coverage. During the COVID-19 pandemic, we saw what Rwanda was able to do, and we also saw Morocco, what they were able to do in terms of using their primary health care system to be able to respond to the COVID-19 pandemic on one hand, and also to be able to continue to run those essential health services as far as their countries were concerned. Now, the big question before us today is how do we strengthen our primary health care system in such a way that they are able to address the broader issues of emerging, re-emerging, and endemic diseases. I think that's what we should be looking at today. And we know clearly well that Dr. Tedros of WHO did mention the fact that both universal health coverage and global health security are two sides of the same coin. And again, Rwanda and Morocco have actually proved him right as far as that statement is concerned. In terms of what we need to do, our head of state and government, the African Union head of state and government, have called for a new public health order that is underpinned by one strengthening of our health institutions, public health institutions, our research institutions, be it at the continental level, the regional level, sub-regional level, or at the national level. They have also called for the need to expand our workforce capacity, the need to really strengthen a workforce development on the continent. When Landry was talking, he did mention the fact that we need to strengthen the community health workforce. We need to strengthen our community health system. Because one thing is clear, be it epidemic, be it pandemic, even be it endemic, they all begin and end in the community, which further underscore the importance of that. We need to continue to expand our local manufacturing capacity for those health security commodities, vaccines, diagnostics, therapeutics. Because whether we like it or not, there is no way you can talk of strengthening a primary care system whereby you have to rely on the goodwill of some other member states or some other country that are not on your continent. So we need to shift that needle from manufacturing just 1% of vaccine needs to 60% come 2040 as articulated by our head of state and government. We also need to begin to look at how do we mobilize resources domestically. The issue of donor dependence, I think we need to begin to move away from that, of course, strategically. But we need to find a way to begin to mobilize resources domestically, to be able to strengthen our primary care system. Last but not the least, we need respected and action-oriented partnerships, to strengthen our PHC, to strengthen our healthcare system. We know today there are so many partners doing different things one way or the other in different places. But what is lacking are the priorities aligned with our national priorities. So we need a lot of coordination, communication, cooperation, and collaboration in that space in order to strengthen our primary care system. And going forward, community engagement is key. And African Union continue to emphasize on the need for us to embrace the culture of the whole of society approach, when it comes to any health agenda, because that's the only way we can have, acceptability and ownership from our community. And Africa CDs continue to work with different stakeholders to ensure that. There's also a very important need for us to find a way to get to the vulnerable population. Because when you look at the definition of primary care system, no one should be left behind. So today, we have forgotten about that equity that ensure that nobody is left behind. So we need to continue to apply equity lens to whatever we are doing. Today, we know there are so many resources, so many support in terms of infrastructure that is trickling in, that is coming in by way of response to the COVID-19 pandemic. So the onus is on us to ensure that we appropriately channel all the resources, to strengthen our primary care system, so that the health system or the PHC or the universal health coverage is not only addressing the day-to-day needs of our populace, but they are also able to have to be able to respond, when the need arises, when another pandemic comes, there should be a way that our system, the PHC, is able to respond in a very robust manner before such outbreak becomes epidemic or even become a pandemic. Colleagues, ladies and gentlemen, we have so many decisions. We have so many call to actions. We have so many frameworks. We have so many initiatives. But all these largely, they remain documents on our shelves. So I think one of the takeaways for me from this session is to go back, revisit those documents, those frameworks, those call to action, and let's come up with how do we walk the talk as far as those documents are concerned. Madam Chair, I would like to stop at this junction. Thank you.
Wow. For just the short time you have, we thank you very, very much, Haji, for that presentation, wakening us up on what we really should be doing, that whole list of what we should be doing to strengthen primary health care system. There is one that really goes into my bones all the time. It's the one on mobilizing domestic resources. We keep hearing about this and these domestic resources. I don't know what we're going to do to get them to come out from where they are and get into where they should be. So anyway, thank you very much for that. And thanks for having such a short time, the three of you, for joining us on this panel and for these really elegant presentations. I'd like to move on from here. I know Professor Mbacham is the moderator, but since I had to incorporate him as a speaker, I'd just like to turn to him first with the first question, and then he can take on later on, after this. And I'd just like to know from you, Professor Mbacham, many countries are moving speedily towards universal health coverage. Most are giving priority to infectious diseases. And is there something African countries are missing?
Well, I thank you, Prof. And I think it's, again, just wonderful to share the podium with all these other eminent speakers. I did mention when I spoke that we needed to expand universal health coverage to also integrate the non-communicable diseases, because we know that these are also on the rise. And nowadays, people are not talking about diseases again in their silos because somebody is not necessarily always or uniquely infected, for example, by malaria, but malaria comes upon an individual with other disease states. So it will be important and necessary to have these integrated as we address all of the issues that need to be covered by universal health coverage. The other aspect is that the universal health coverage does not have to be central. If you look at the Canadian health system, you notice that each of the different states have their own universal health coverages, and people can decide to reside in one area and not another area because the health facilities and provisions make it such that people may desire to reside in one area and not the other. I think importantly and very upfront, we need to currently look at the models that are working and ask that people should go into extensive partnerships, because this is the only way that it can happen. And the private sector is one such a wonderful model, because if a petroleum industry, for example, is settled in one region, they can decide to provide for health for all by the petroleum dollars. And I think above all, I think one of the speakers did mention, it is to digitalize health. There's a lot of big data that is being spilled out, and we are not harnessing those. And so very early on, each country needs to train necessarily the medical doctors, but also people who are able to analyze the health into these new areas of analytics that would attract and provide the necessary data for policies to be enacted, and then for universal health coverage to be effective. Over. Well, I guess I will turn now to Monique and ask what she thinks about NTDs and the context of achieving universal health coverage, because her whole passion is about the neglected tropical diseases. Monique.
Thank you very much, Prof. So maybe we think about the numbers, yeah? As I said, 1.7 billion people affected by NTDs, and 40% of these people are in Africa, and half are women and children. So numbers don't lie, so we start from there. And these are very poor people. They're living in abject poverty. They are really marginalized. They are voiceless. And really, some of them live in conflict zones. So they've been neglected for very long. And very little research and development is being done. There's very little funding also not coming. And if you have the concept of universal health coverage, it means that the individuals and the communities will receive health they need without suffering additional financial costs. So already the neglected populations are left behind. So we have to bring them to the level, yeah? And increase the kind of research and development that needs to be done, because really without research and development for these neglected populations, we will not be able to deliver the universal health coverage, period. We will not deliver. So we have to recognize that 40% of NTDs are in Africa, and we need to do something about it. And I'm happy to also let you know that African Union already has they've thought about this and developed African Common Position on NTDs, and also the Continental Framework on NTDs. So something is being done. But I wish we could have the speed of COVID, where the whole country, all the countries come together, money is collected, and we see as Africans that we are not doing anything for our people. Then the president say, okay, this is what we do, African Union, Africa CDC, we get ourselves, mobilize ourselves, everyone. We wouldn't have these entities. Yeah? Yeah. Yeah, so that's my comment.
I'm not quite done with you. I just like you to extend the whole concept of neglected, and for tropical diseases to also to expand to the areas of the big infectious diseases, in which there are areas of those diseases that are also neglected. And these also need to be addressed.
Sorry. Yes, there are infectious diseases where, like for example, in HIV. HIV in itself is not neglected, but the children are neglected because until now, they didn't have medicines to treat the HIV, which were, conducive for them, which were palatable. The medicines were bitter, they had alcohol, or they break the adult dose. And so, the population there was neglected. But the HIV itself is not neglected because it's a global problem, and there's a lot of research and development. and there's a lot of money coming in, unlike other infectious diseases which are neglected, like I talked about sleeping sickness and leishmaniasis.
Okay.
Yeah, and also like hepatitis C, for example, is an infectious disease. But it's not neglected, but the population is neglected, especially in the poor countries, because the treatment is thousands of dollars for 12 weeks. It used to be $84,000. So now we want to bring it down to maybe at least $300 or so, and that's why like DNDI is involved in the space of hepatitis C, for example.
Absolutely.
So yes, there are pockets of neglect, and that's our philosophy. We go in the places where there is neglect. We don't duplicate the wheel. We just have a niche where it's neglected, we go there. That's
Well, thank you. Thank you for sharing this with us. And in the hope that the bottom billion in Africa would be attended to, the question that arises, which I'm going to ask Landry to address is, with the lens of what is needed to keep us all safe, certainly there's going to be a next pandemic. What should we be doing?
Thank you for this question. First of all, before we think about the next pandemic, we need to learn from the current one and also the current epidemics. One important lesson that we all collectively learned from the COVID-19 pandemic is that when the disruption and the lockdown were imposed, what we were left with was our community health worker. They were at the forefront at community level, ensuring that people with chronic diseases or needing day-to-day treatment like HIV treatment, antiretrovirals, will receive their medication. They were at the forefront, supporting communities in doing contact tracing. They were at the forefront, supporting delivery of other life-saving interventions like nutrition for malnourished children. I think today, before we think about what will happen with the next pandemic, we need to acknowledge that investing in our frontline worker, institutionalizing them, providing them with the right cadre, the right remuneration, is the right investment. It's not a spending, because the return that communities and countries got during the COVID-19 response is incommensurable. That's my first message. The second message is that we all witness the increasing access to new technology, increasing access to digitalization. But at the bottom line, our hard-to-reach communities, I mentioned the zero-dose communities, where you have the highest proportion of children who are non-immunized, where you will find those children and adults with poorly diagnosed, neglected tropical diseases. What should we do differently if we have all the tools today for diagnostic and for treatment? I think what we need to do differently is how we look using our current programming lens at our zero-dose communities. They are left behind. These are the communities also facing the impact of conflict, the negative impact of climate change. We know those communities in most of our countries. We need to think differently around local development. We need to think differently about devolution of authority, because unless we get closer to the zero-dose community with resources, with community-based programming, because the solutions to the issues they are facing should come from them. We need to think bottom up as we move forward and we prepare for the next pandemic. Thank you.
Thank you very much. Thank you very much. I know we need to get to this zero-dose community, but when you look at even the major diseases, for example, malaria, you still have so many deaths. And the question which I'm asking Christine is, giving your views on where we are currently with the fight against malaria, what do we need to do dramatically to reduce the number of cases and the number of deaths that are still occurring on the continent, even without a pandemic?
Thank you very much for that question, Prof. Indeed, malaria still continues to be ravaging the communities. We still have so many deaths, unnecessary deaths, because of malaria. We really ought to do more. I know a lot has been done, but I believe that we can still do more. First and foremost, it is a breakthrough that we do have a vaccine in our midst, which is really a yardstick that seemed so far to be reached. You know, looking at how we've moved with COVID, to have gotten to where we are today with the vaccine after the so many years that have passed is really something so sad. We wish that we could have moved, even with malaria, to have ensured that we would have had the vaccine much earlier. So I think that we still need to invest so much in making sure that we do get vaccines that will be able to have better ways of being able to ensure that the people are protected. Beyond that, I still think that there is need to look at the drug side of it. For the drugs, the antimalarials, we still could do better, you know, in ensuring that we have the curative drugs that are better complied to. So research to ensure that there is a way in which we can enhance compliance, to ensure that, because the current antimalarials that are available are still requiring to have 3 days of being ingested for one to be able to get the full treatment that is prescribed according to the label of each of those artemisinin-based combination therapies. And I think we need to do better to get to a point where we can have even just 1 day or single dose treatment that will be able to save lives. And I think research to ensure that we get there is also extremely important. Now, those are the drugs for treatment, but also chemoprophylaxis. The drugs on chemoprophylaxis should also be taken into serious consideration. The fact that what we use for curative ordinarily cannot be used for us to be able to ensure chemoprophylaxis. We need to also invest further. We know that for chemoprophylaxis in pregnancy, we have issues of resistance to SP, and we've had all these issues of the parasite being resistant to SP and having this diversity within Africa. I think that the alternative ways of being able to get something that can compete favorably with the SP, sulfadoxine, pyrimethamine, for the prevention of malaria in pregnancy is another area that we should ensure that we work and get ways of preventing the pregnant mother getting malaria and us losing 2 lives unnecessarily. Further, we have an unmet need when it comes to just the general issue of treatment. When you look at the label for the artemisinin-based combination therapies, the children who are less than 5 kgs are not even covered. So for children that are born with congenital malaria, or indeed who get malaria and who are less than 5 kg, the label does not cover them. So it is important for us to be able to ensure that unnecessary deaths are avoided by investing also in making available medication that will cater for those children that are not in that area. We've made a breakthrough, I think, in the first trimester treatment for malaria. Only recently, on the 25th of November, we got WHO revising the guidelines. We were having unnecessary deaths in the first trimester because a woman would not want to continue the quinine, knowing how the issue of tolerability with quinine has been going on. And so many years did we invest, Professor Rose-Leke can bear witness, so much work had been done to just try to prove how much of artemisinin-based combination therapy safety there may be, so that we could see whether the relabeling or rather the availability will premise us on a very safe and efficacious standpoint for first trimester pregnancies. And now WHO has given us that, so at least we know we are getting there. But beyond that, I think there is need for concerted effort in country and cross-country, because talking about insecticide resistance, talking about drug resistance is not a one country alone. There has to be that inter-country effort to ensure that there is conversation and there is co-planning and financing of efforts. The mosquito knows no boundary. It will cross into another country and be able to take its resistant pattern from another country where a certain IRS is being utilized. So unnecessary deaths due to malaria need to be combated quickly.
Well, thank you very much. And we're running out of time. And I know these questions are so passionate. And please do contact the different speakers after this session. I'll just like Raji to conclude. You've heard all that we've said. What would be your one take-home message if you had to give us one?
No, thank you, Chair. So I think for me, I say go back to the topic of this particular session, which is strengthening universal health care in such a way that we are able to address broader issues, including the endemic diseases, the epidemics, the pandemics, and the day-to-day issues. And to do this, our head of state and government, they've clearly, identified the need for a new public health order, which I did mention in the course of my presentation. And in terms of financing, which Professor Leke did mention, domestic resource mobilization, we also need to ensure that adequate resources is allocated to health. Today, we know that just very handful of our member states are actually, hitting that target of 15% of their GDP to go into health. There's no way you can guarantee a very good or a universal health coverage in the absence of adequate financing. That's number one for me. Number two, we have so many partners doing different things. And unfortunately, many a times is unnecessary duplication of effort, unnecessary duplication of resources. I think going forward, we need to come together. We need to coordinate. We need to collaborate. We need to communicate. And much more importantly, we also need to make sure that we listen to the voices on the ground. Community engagement is key. Last but not the least, we've seen so many resources coming through COVID-19 pandemic. My co-panelists on the right side had mentioned that can we apply what we have done to COVID-19 to neglected tropical diseases? For me, I would say let's apply it to the broader health issues, So that sort of a response, that sort of speed, that sort of scale, let's apply it to our primary health care system. Because whether we like it or not, a very strong primary health care system will address the day-to-day essential health issues and will also address our health security. Thank you, and over to you, Chair.
I guess we're going to take one or two very pertinent questions that you must ask now or forever hold your peace. We have one hand on this side. And another on the other, on the middle aisles. Just those two.
Thank you very much for this opportunity, and it's been a delight to listen to these great insights from the amazing work being carried out by all the presenters. I will address my question to Professor Mbacha, being aware that he just stood in for someone. But I'm first of all fascinated by the specific deliverables which you illustrated regarding universal health coverage in Cameroon, including the overarching strategy of federation. I would like to know if there is already a specific plan regarding the mechanism for pooling of the funds to sustain this universal health coverage project. Also, is there an allocation strategy to ensure equity to support the regions in a rather non-federal government? Thank you very much.
Okay. There's a second and last question.
Thank you very much, distinguished panelists. My name is Ambrose Talisuna. I think we really need to be asking some tough questions. And Landry, I think there are certain low-hanging fruits for UHC that we are really not doing. If you look at the continent now, 25 African countries have measles outbreaks. We have a measles vaccine. What are we doing wrong? Christine, if you look at maternal mortality in Africa, Sierra Leone, over 1,000 mothers still die per 100,000 childbirth. Really? The same in Sudan. Can't we do something to those mothers now? Isn't that a low-hanging fruit? And Taj, we've really talked about this new public health order, domestic financing. Since Abuja, we've talked about domestic financing. We increased domestic financing. It is not moving. What are we doing wrong? Everybody says health system strengthening is not a sprint, it's a marathon. When will this marathon start and we start another?
Okay. So I guess since I'm moderating, I'll take my own question last, and Landry, then Christine. And please be brief, because we have just 0 minutes remaining.
Let me start by saying I fully support your points. What did we go wrong, and what can we do differently? I think it's not the time for statements and promises, it's time for action, as mentioned by my co-panelist. But we know the issues. The first issue is not new. The COVID-19 uncovered clearly a very fragile health system, poorly funded, frontline workers not recognized as a full cadre in our healthcare system. We all witness the backsliding of immunization coverage in most of our countries. That got exacerbated during the COVID-19 pandemic. So the outbreaks we are seeing today, as I mentioned, is a result of that weak health system. It's a result of our inability to reach the zero-dose communities and leaving millions of children without life-saving vaccines. I think we know, that's my point earlier, it's not going to be about having new tools, because we are not doing enough with the tools that we have. Our strategies are not getting the most effective tools closer to those in need. We need to fix that in our system. We won't bring those tools, those solutions, those vaccines, those drugs to the poorest community, hard-to-reach community, unless we have the right cadre in our health system to go and get there. You will not bring a doctor there. You are most likely to bring someone from that community who is well-trained and who is well-accepted. My last point, why are we not looking at community health worker as an investment with the greatest return? That's the mistake that we need to fix now. And we are all proud that the head of state, through the African Union, have endorsed the initiative of having 2 million trained community health workers deployed in all the 55 member states to ensure that we fix that healthcare worker gaps, to ensure that whatever we have as new technology to fix the issues, including maternal mortality, we should start by fixing the issues of child mortalities now. Thank you.
Thank you. Christine, 30 seconds.
Talisuna, I totally agree with you. The maternal mortality in the continent of Africa is totally unacceptable. And I look at it as an issue that requires, it's actually an emergency in as far as I'm concerned, because a maternal death is an emergency in as far as I know. And it is also such a sad thing, because at the end of the day, in certain circumstances, you have the death of the mother and the child together. So I believe that there is need to address, from one point, the human resource for health. That is one area where equity of access to health care has been an issue, where the access, once the mother has accessed the health facility, the actual human resource may not be optimum to be able to take care of the mothers that will have presented early enough to be taken care of within the facilities. The issue of, that has been spoken, of funding, the government being precise and deliberate to be able to increase funding to health, to ensure that even the sector of reproductive health is taken full care, that it is catered for, cannot be overemphasized. Because you cannot talk about human resource for health to be able to have obstetricians, midwives, without having to deliberately make an effort to ensure that people are trained and are able to make provision of the human resource for health. That must be emphasized. When it comes to diseases that will cause maternal death, like malaria, like I spoke earlier, it is important that it is recognized that early treatment is provided, but without information reaching to the mother in good enough time, how will they be able to know, when to access and how soon to access the health facility? And to have efficacious drugs that will be able to be taken all through the trimesters is one thing that has been ensured to be taken care of now. So why doesn't the drug get to the person who needs it, who is the mother, unless they have gotten to the health facility as soon as possible? To underscore everything, early antenatal attendance is something that cannot be overemphasized. Unless a mother is seen from the very early stage of her pregnancy, we are likely to have issues in that pregnancy, and much more worse if their area of residence is far away from where they should be able to get the care. So the issue of making sure that early antenatal coverage is taken care of by ensuring equity of access to the health facility and taking care of how to provide services as near to the family as possible is extremely important. So in short, Talisuna, I totally agree. Something must be done, and done soon, because we shouldn't be having one mother dying is one too many. One mother dying is just one too many, and worse if she dies with her baby. Thank you.
Okay, Christine, I think we've gone past our useful time on this stage. I think on behalf of Prof. Leke and myself, we really want to thank the panelists, especially those who at short notice called up to discuss. I think this is something in your hearts, and I think you've really poured it out to the rest of the audience. And thank you very much, and let the discussion continue after this over coffee and the next day that we're still around. Thank you so much.
Each of you gets out here, make sure, our heads of state signed the Declaration on Immunization. Macky Sall, President of Senegal, had a forum on Saturday again on routine immunization and on polio. Please look for this. Why do we have all these 0 children? Why are we having so much measles, like it was asked here, measles and cholera outbreaks? Each person go out, find those 0-dose children, and see what each one of us can do. Let us not just talk about it, let's see some action. Thank you very much.
Thank you. We're running a little behind schedule. We're now going to go to track 9, non-communicable diseases, a growing public health threat in Africa.
Hello. Good afternoon, everyone. I would like to invite whoever will be presenting at this session to come in front. Thank you. Go ahead. Okay, thank you. Well, welcome everyone to this abstract session that falls under track 9, non-communicable diseases, a growing public health threat in Africa. My name is Umulisa Marie Michel, Executive Director at Linda Uzima, and I will be co-chair moderating this session. By NCDs, we understand chronic diseases, often caused by modified and non-modified factors that can be classified under genetic, physiological, environmental, and behavioral factors. Globally, estimates from the World Health Organization demonstrate that about 70% of all deaths globally are contributed to non-communicable diseases. In low and middle-income countries, as of now, NCDs deaths mostly happen before the age of 70, leading to about 6% of premature death. Everyone without discrimination of social demographic factors is at risk, whether from unhealthy diet, physical inactivity, exposure to tobacco smoke, or the harmful use of alcohol. In Africa, the World Health Organization has revealed that by 2030, the burden of NCDs will surpass that our infectious diseases, leading to an overall increase of 27%, which 20 million more deaths from NCDs in Africa. So hence the need to tackle the threat. In this session, we will review the epidemiological NCDs, mental health, and injuries in Africa, discuss challenges in achieving universal health coverage for mental health in the African context, explore process for integrating NCDs, mental health, and injuries into all levels of healthcare services, and identify opportunities for increased direct and indirect funding for NCDs. Mental health and injuries programs among Africa member states. With this framework, presenters will discuss, among others, cancer, diabetes, body weight, hypertension, etc., and will guide us through their work in their respective field. With that being said, I would like to invite and introduce the session's co-moderator, Gabe Mbaile, Communication and Public Relations Manager at Ndabuzima, for this session's proceedings. Welcome, Gabe.
Thank you very much, co-moderator, for the introduction. It is a privilege to co-moderate this important session around non-communicable diseases. Before I introduce our distinguished presenters, I would like to set some ground rules. All the presenters will have 10 minutes to cover their topic. We invite the audience to hold on to their questions and write them down for the Q&A session after all the presenters have finished their presentation. Without further ado, I would like to introduce our first presenter, Dr. Michael Girma Mamo, who is affiliated with Myeongsang Comprehensive Specialized Hospital. His presentation is titled, "The Magnitude of Non-Adherence and its Associated Factors Among Type 2 DM Patients on Oral Antidiabetic Medication Attending Public Hospitals in Addis Ababa, Ethiopia, 2022. A facility-based cross-sectional study." Welcome, Dr. Michael Girma.
Good afternoon. I am Michael Girma. I am a recent medical graduate from Myeongsang Medical College, Addis Ababa, Ethiopia, and I'm currently working as a general practitioner at Myeongsang Comprehensive Specialized Hospital, and it's a privilege for me to not only attend this conference but also to present on it. It's really, I'm really grateful. So I'll be presenting an article, an abstract titled "The Magnitude of Non-Adherence and Associated Factors Among Type 2 Diabetes Patients on Oral Antidiabetic Medications Attending Public Hospitals in Addis Ababa, Ethiopia." So basically, as we all know, diabetes mellitus is a metabolic system disorder, a group of metabolic system disorders that are characterized by hyperglycemia, and it's a chronic medical condition that requires a chronic medical attention. So coming to the introduction, the epidemiology of diabetes. So as you can see here, this picture was taken from the International Federation of Diabetes, and it's a data from 2015, and as you can see here, it's actually the WHO estimates that there are around 537 million people currently living with type 2 diabetes as a whole, and that number has tripled from the figure that was in the year 2000. So as you can see here, the United States, China, and India are the countries with the highest percentage, or with the highest percentage of their population living with diabetes. And as coming to our continent, Africa, again, this is taken from the IFD, and as you can see here, the darker the shade gets, the higher the percentage of the countries, their people living with diabetes mellitus. So it's estimated that around 24 million people are currently living with diabetes in Africa as a continent. And this number is estimated to, or predicted to increase to 55 million in the year 2045. And almost 13 million people are currently undiagnosed with diabetes, and that's more than 50% of the already diagnosed ones. So coming to specifically to my country, Ethiopia, it's estimated that currently there are 2 million people living with type 2 diabetes mellitus. And coming to my main topic here, medication adherence is the extent, is defined as the extent to which a patient acts in line with the specific interval and dosing of dose of a dosing regimen. And 32 out of all the cause for treatment failure, up to 30 to 50% of the cause can be attributed to low adherence to drugs. And WHO currently estimates that up to 50% of the whole population who are currently on anti-diabetic medication are non-adherent. And this is mainly due to research done here in Africa, where the adherence rate is very low. For example, in the Western countries, consistently the adherence rate is above 80%, and in some Scandinavian countries, it's above 95%. So mostly it's because this lower percentage of non-adherence adherence is because of the research done in Africa, and Ethiopia is no different. So on average, up to 50% of the population is adherent to their medication. That means 50% are not adherent. And these researchers attributed the lack of funds, limited access to health facilities, and low literacy levels as a cause for, as a predictors of non-adherence. And this research basically try to evaluate the level of non-adherence to oral anti-diabetic medication using the standardized scale method, which is the Morris's medication adherence scale, which is standardized and currently accepted worldwide. And the methods we used was, this is a quantitative multi-facility-based cross-sectional study conducted from February up to April of 2022, and the final sample size was 367, and the inclusion criteria were the patients had to be above the age of 18 with capable of consenting on oral anti-diabetic medications and follow up at the selected hospitals for more than 6 months. So this is what we did. There are currently 21 public hospitals in Addis Ababa. Out of those, simple random sampling was used to select 3 of them, and proportional allocation was given to those selected hospitals based on their patient flow to their diabetic clinics, and then systematic random sampling was used to select the individual participant. And adherence was evaluated using the Morris's medication adherence scale, which I already mentioned earlier, and 2 scale questions. That's to assess their knowledge and their relationship with their healthcare provider. 2 scale questions were adopted and were used, and data analysis was done with SPSS, and bivariate and multivariate analysis were also performed, and p-value of less than 0.05 and 95% confidence interval was used as to determine factors that were significant. So the mean age of the study participant was 58.3 with plus or minus standard deviation, and sex distribution, most of them were males or females, 53% of the study population. And some of the factors we studied, almost 1/3 of the study participants had a family history of diabetes mellitus, and some of them used, almost more than half of them used religious practices to heal their diseases. And some of them, up to actually 13 participants stopped their medication in order to practice their religion to cure their diseases, and some other factors. And almost 92% of the patients, the study participants reported that they had a good relationship with their healthcare providers. So coming to the main parts, with the Morris's medication adherence scale that we used, we identified that up to 65% of the patients the study participants were adherent, and 35% of them were non-adherent. And so the Morris's medication adherence puts questions such as, do you forget your medication? If you look at the scales questions, there are 8 questions, and it evaluates the core parts of making patients not adherent. So one of the questions was, how many times do you forget to take your medication per week and per month and such? And most of them mentioned that it's because they forget that they could not take their medications. So coming to the logistic regression analysis of the study, the non-adherence to medication, so the most important one that we found was religious practice, like up to those who practiced their religion in order to cure this disease or their diabetes, they were 9.2 times more likely to be non-adherent when compared to those who do not. And that it was statistically significant with 0.01. P-value of 0.0. And those who had no moral support from their families and friends, they were almost 9 times more likely to be non-adherent. And also those who had family history of DM, and those males were 3 times more likely to be non-adherent, which is consistent with other research done in Africa as well as in the whole continent. Those who had good, poor relationship, almost 3.5 times more likely to be non-adherent, and those who reported side effects, they were 2.3 times more likely to be non-adherent. And education, those participants who were given education through pamphlets or brochures or video or audio educations, they were, those who did not had this opportunity, they were 5.5 times more likely to be non-adherent. So the most significant that we found was the religious practice, moral support, those who had family history of diabetes mellitus, those being male, and those who had poor relationship with their healthcare provider, those who reported side effects, and those who were not given education regarding diabetes mellitus, they were more likely to be non-adherent than their counterparts. So in conclusion, this study found a significant rate of non-adherence, that's up to 35% compared to with other studies. Usually that 50% that I put, so most of the studies, they did not use the standard, as I mentioned earlier, they did not use the standard method or scale to identify or evaluate medication non-adherence currently. That's the MMS. So this variability in the research results could be explained by that. But some even found up to 27% of adherence, that's 73% non-adherence. So compared to those, we have found a significant rate of non-adherence, and the most common reason identified for medication non-adherence in this study was forgetfulness, and religious practice and lack of moral support from friends and families were found to be significantly associated with non-adherence to their oral anti-diabetic medication. Thank you very much.
Thank you very much, Dr. Michael Girma, for let us go through your study. I would like to present our following presenter, Mr. Aphrodis Hagabimana. He is a Rwanda Field Epidemiology and Laboratory Training Program alumni in the Department of Epidemiology and Biostatistics at the University of Rwanda. He will present prevalence of hypertension and associated factors among people living with HIV, a cross-sectional study in Rural Hospital, Rwanda. Please welcome Mr. Aphrodis.
Good afternoon. Welcome to my presentation. Prevalence of hypertension and associated factors among people living with HIV. My name is Aphrodis Hagabimana. I'm working at the Kigeme District Hospital here in Rwanda. So, hypertension, it is also called high blood pressure. It is a chronic medical condition in which the blood pressure has risen. So globally, it is a major public health burden and the most leading risk factor of cardiovascular disease. Each year, it affects more than 1 billion of people worldwide are affected by this silent killer of hypertension, and cause approximately of more than 15 million of people are dead. of which 80% of them are located in sub-Saharan Africa. So this hypertension become high burden among people living with HIV. However, like many other countries in sub-Saharan Africa, there is limited data on hypertension among people living with HIV. So the reason why we have conducted this study aimed to determine the prevalence of hypertension among people living with HIV. So in this study, we have used a cross-section study to determine this prevalence and also the associated risk factors. The interest of our study as hypertension was defined as having historic blood pressure, where systolic was defined as having greater than 140 millimeter of mercury, and or having diastolic blood pressure greater than 90 of mercury. So we used a structured questionnaire, which was predetermined by WHO for stepwise approach, surveillance of NCDs, risk factors, where the questionnaires were grouped in 4 categories: social demographic information, information relating to the social lifestyle, information pertaining to the medical condition, and also anthropometric measurements were taken. So for getting a sample, a systematic sampling method were used to collect the sample of around 386 of people living of HIV among of 3,000 people under follow-up in these study areas. So for our setting of our criteria, one was being among 18 years and above. So the variables were computed in a multivariable logistic regression, where the results were presented in a frequency and a percentage. And also we used the software like PFO for data collection and Stata for data analysis. So as the result, the most participants of our study were women at greater than 63% of our proportion, and the mean age was 47 years. But for the all result, the prevalence of our study was 29.80%. So as you see in the distribution for hypertension by age group, there is increase of hypertension among people aged 15 years and above. So after performing results in a multivariable logistic regression, those people who were long duration on antiretroviral therapy were greater than 5 years, and adjusted odd ratio was 2.9, where underweight of people living with HIV had lower odds of developing hypertension. So underweight had adjusted odd ratio of 0.2 compared to normal weight. So by conclusion, hypertension was higher in this study, and people living with HIV were longer duration on ART, and overweight had greater odds of developing hypertension in this study. So at the end of this result, we have found that this highlighted the need to reduce hypertension among people living with HIV in our study population by targeting those who have higher duration on ART and overweight. So finally, we would like to acknowledge the following institution: the government of Rwanda, University of Rwanda, Minister of Health, RBC, and AFENET. So by concluding, so let us work together to build African we want. Thank you very much.
Thank you very much, Mr. Fredis, for even using less time than the allotted time. Thank you very much. I would like to introduce our following presenter. She is the Director of Nursing at the University of North Carolina Project and an adjunct assistant professor at University of North Carolina School of Nursing, Chapel. Her presentation is titled Client Perspective on Integrating Facility and Community-Based HPV Self-Sampling for Cervical Cancer Screening with Family Planning in Malawi. She has conducted a qualitative study. Please welcome Dr. Agatha Tianjani Bula.
Thank you. Good afternoon, everyone. As you have heard, I'm Agatha Bura, working with UNC Project, and my presentation is focusing on the findings from the qualitative study we conducted with women in Malawi. So this was part of a larger cluster randomized trial. So just a brief background. Cervical cancer is one of the leading causes of death among women in Malawi, and mainly this is because of lack of screening in the country and also high HIV prevalences that lead to progression of the disease. And we are all aware that cervical cancer is preventable if detected early as well as treated early. But so in Malawi, currently we are using VIA for screening women and also abrasion treatment. And then we are looking at the statistics in terms of screening. We are quite low, whereby only 26% of women are able to access the services. And those who are screened, looking at those who are positive, only maybe about 50% or 52% are the ones who get treated in the country, because most of the facilities, though they offer the screening, but they don't offer thermal ablation. And there are some challenges which women are facing to access cervical cancer in Malawi, including long distances to the hospital, as well as lack of knowledge on where they can get the services. So we conducted a qualitative study as part of a larger cluster randomized study, which I already said. So this was a study which was randomized in health facilities, either to facility-based self-sampling or community-based self-sampling using the health workers. So we used the HSAs, whom we call, who are working in the communities to help with the collection of the samples. So what we did was we went to the facilities, met the facility in charge of those people who are involved in the program, to help us with the identification of the participants, as well as finding us a place to do the interviews. So we had a guide which we used to conduct the interviews, and all the interviews were conducted in Chichewa. They were audio recorded, transcribed into English for analysis. So we had a total of 29 women, which were distributed as in model 1, which was just collecting samples at the facility and getting results there. We had 9. And for the model B, whereby they were collecting either results, samples in the community or at the facility, or get the results in the facility. So we had different groups, some were 7, 6, and then the last one is 7. So after collecting the data and transcribed, we started the analysis throughout the data collection period, whereby we tried to familiarize ourselves with the data, and that also helped us to determine our sample size, because we didn't want to collect repeated data. So then we generated a code book through the use of 3 transcripts. So this work was done between UNC and the Cameroon University of Health Sciences. We worked together to analyze the data. And then we coded the data, and 50% of the data was double-coded by 2 people. And then we continued to identify the themes which were coming out from the data. And then what we did was to produce the narratives from our data. So what we found was that we tried to find out from women what motivated them to be screened for cervical cancer despite just hearing about it at the health facility. So what we saw was that women felt empowered for collecting the samples on their own, and they decided also to just make a decision after hearing about cervical cancer at that facility as well as in the community. They went to the facility for other ailments, but they were able to, after sensitization, they immediately made a decision and they had the screening. And we also saw that most of our women, they experienced, they were also felt at risk of having cervical cancer because of the knowledge about HPV being sexually transmitted. And some of them admitted to say, my partner is promiscuous. I know what she does, so I wanted to confirm whether I have it or not. And some of them, they have the knowledge on the importance of early detection of HPV and treatment to prevent further spread. And others also, those who are HIV positive, they understood the importance of getting tested every year when you are HIV positive. And then we also looked at some of them who also mentioned about experiencing some problems, especially gynecological problems, like having an abnormal vaginal discharge, which they also associated with, they felt they might have cervical cancer screening. Another interesting finding was about the PV breeding, especially those who are on family planning. Despite knowing that most of these family planning methods, they cause breeding, they were able to undergo cervical cancer screening to rule out whether it's cervical cancer or not. And some associated with some bad obstetric outcomes like neonatal death, SB, abortions, as maybe being contributed by the cervical cancer. We also looked at the satisfaction with self-sample collection. So what we saw was that women were happy to collect the samples on their own, and they were happy because nobody was seeing their private parts. There was a lot of privacy because sometimes the VIA was done by male healthcare workers. And also they were also happy because it was faster to collect the sample, and some were able to get the results on the same day. And also they considered self-sample collection as painless compared with the use of the speculum through the VIA. And then the majority also expressed confidence on the samples they collected, so they trusted the results which they got. Because this was also confirmed when they were getting the treatment at the hospital. And then we looked at the actual acceptability of the two models. What were the similarities? So what we saw was that all the two models saved time, because at the hospital they were able to access two services at once, whilst at the community they were just screened in the community. There was also a lot of demand creation whereby women were able to motivate each other in both the community as well as the hospital, so more people were getting tested. And then we also saw that they mentioned about privacy, to say in the hospitals, especially those low-density hospitals, they were able to take samples in the toilet, whilst in the community they were able to collect samples in their homes. And there was also trust for both on the providers in both the two models. And then we looked at the differences. The main difference we saw was they were related to the waiting time. Especially at the hospital, whereby they have to wait to go to the toilet, get the sample, or also get the results, because they were getting the results on the same day, whilst those in the community, they were getting the results on another day. And then we look at the issues of privacy. So in the hospital, some talked of, congestion at the hospital, where they have to collect the samples in the toilets or in the office of the healthcare worker, where he's also there with them. And whilst in the home, they were collecting samples in the bathrooms and their own bedroom. And also access to information was better for those who were at the hospital compared in the community. And also, informed decision was more for those in Model 1 than in Model 2. So in all, we saw that these women, despite making their decision on their own, the disclosure was high to the spouse as well as to significant others, because if they know if they fall sick, they will need support. Whilst we also found that And none of them reported social harm, which was one of the plus for this study. So in conclusion, we found that both the models were favored by women, and also we found that women, you know, as already said, women were able to make decisions on their own without consulting others, despite the gender issues, and disclosure was high to significant others for support. Self-suffering was also highly accepted by these women. So this study was funded by the USAID, and these were the implementing partners. Thank you.
Thank you very much, Dr. Tianja Nebola. I would like to introduce our next speaker, Dr. Ekwoge Dian Dion. She is affiliated with the RSD Institute in Cameroon and will be presenting body weight misperception and its association with weight control behaviors and mental health in adolescents in secondary schools in Cameroon, Global School-Based Health Survey 2018. Please welcome, Doctor.
Okay, good afternoon. Okay, thank you for giving me the floor. I am so honored to address this distinguished audience. We are going to be presenting our research findings on body weight misperception and its association with weight control behaviors and mental health in adolescents in secondary schools in Cameroon. A global school-based health survey carried out in 2018, funded by the World Diabetes Foundation and implemented with technical support from the RSD Institute. Without any further delay, what is body weight misperception? It is actually a discordance or a disagreement between an individual's actual weight status and his or her perception of their weight. It is divided into two categories. We have underweight misperception and overweight misperception. Underweight misperception is when the individual's measured weight, the BMI, is high, but the person actually perceives himself as having a low weight. And overweight misperception is when the measured BMI is low and the person perceives himself as of having a higher weight, if I put it that way. So studies have shown that underweight misperception in adolescents reduces weight control and management initiatives, especially in adolescents who are overweight, who perceive themselves as having a normal weight or underweight. And overweight misperception has been documented in studies to increase the incidence of obesity in adulthood. Adolescents who actually were normal weight, who misperceive themselves as being overweight, actually had an increased odds of being obese in their adulthood. Both types of misperception are actually associated with unhealthy weight control practices, depression, and thoughts of committing suicide in adolescents. It is an emerging public health concern and a predictor of weight management practices in adolescents. There are no global and regional prevalences known this far, and while most of the studies have been documented in developed countries, there is no or just one study documented so far in Africa, carried out in Seychelles. A global school health survey in 2007 documented the prevalence of underweight misperception of 15% and an overweight misperception of 36% in adolescents aged 11 to 17 years. So there is scarcity of studies in sub-Saharan Africa, and little is known about this prevalence in Cameroon. So we decided to investigate on its prevalence and its associated factors to enable us to develop programs that are effective in preventing obesity in our setting. So to do that, we did a secondary analysis of a cross-sectional study that was carried out in 3,153 adolescents aged 12 to 19 years in secondary schools in Cameroon that were sampled using a two-stage sampling method. So using a self-administered questionnaire, we collected data on weight perception, weight control behaviors, practices, weight control behaviors, and mental health-related characteristics. Anthropometric measurements of height and weight were measured using standardized instruments, and these were projected on WHO growth curves to generate BMI for age. Well, weight misperception in this study was actually self-perceived weight not matching the calculated BMI for age. And we did a test for association with the different weight control behaviors and mental health and some socio-demographic factors using chi-square test and logistic regression test. So our population profile was the following. We had a mean age of 15 years in our sample, and this was measured by the male adolescents. We had a prevalence of overweight of 20.6%. And while most of the adolescents were normal weight, we had at least a prevalence of 1.9% of underweight adolescents. Okay, so in our study, we documented a prevalence of 33.7% of body weight misperception. This was mostly made up of adolescents underestimating their weight. We had a prevalence of 26.6% of underweight misperception and a prevalence of 7.1% of overweight misperception. Okay. For the types of misperception, we actually had the two types of body weight misperception occurring in our study population, and this was majorly found in adolescents who were overweight and adolescents who were underweight. We can see from the orange bar in the category of overweight adolescents that we had a 69% proportion of adolescents who actually consider themselves as being underweight, whereas they are overweight. And we have adolescents who had 57.6% of adolescents who are actually considering themselves to be overweight, whereas they're actually underweight. And we can actually see from this study as well that the majority of the adolescents who had a correct perception of their weight were actually adolescents in the normal weight category. Compared to adolescents who had a correct perception of their weight, we found that adolescents who have a wrong body weight perception are more likely to be female adolescents, to not use healthy weight control behaviors, to use laxatives, to lose weight, to attempt suicide, and to lose concentration in doing homework activities and some others. And there were no associations found with age and residence. So we conclude by saying that body weight misperception is prevalent in adolescents in Cameroon, and it is a concept that needs further study and that we need to really focus on as a potential barrier to obesity prevention programs, not only in Cameroon, but also in Africa. So we need to create awareness campaigns to implement and to be implemented to reverse these new trends. So the limitations of our study was that it was a cross-sectional study design, so we cannot actually say that we assess the causal relationships between the variables. And due to the method of data collection, we could not exclude information bias and social desirability. And we did not use a standardized instrument to measure weight perception. So we want to thank the Rush for sponsoring us to be here today. And we are ushering special thanks to the World Diabetes Foundation for funding this survey, and to Dr. Joel Sobgui, Executive Director of the RSD Institute, for her guidance throughout, and the RSD's teams of experts for their contributions to the study. Thank you.
Thank you very much, Dr. Ekwoge Dian. I'd like to introduce our following presenter, Mr. Timothy Chereni, who is a program manager with the Clinton Health Access Initiative in Malawi. He will be presenting cervical cancer screening and treatment cascade among women at 5 health facilities in Malawi from March to September 2022. Please welcome Mr. Timothy.
Thank you very much, Chair, for that introduction. Indeed, my name is Timothy Cheren from Malawi, and I'll be presenting on the cervical cancer screening and treatment cascade among women at 5 health facilities in Malawi from March to September of 2022. And we did this with the background that cervical cancer is the 4th most common cancer among women globally. We have heard about this in this conference many times, and I just wanted to re-emphasize that. And most countries that are disproportionately burdened by the cervical cancer disease are in the sub-Saharan Africa. And Malawi, for your information, has the world's highest incidence and mortality rates of cervical cancer. And in 2020, cervical cancer deaths actually contributed 37% of all new cancer deaths among females in the country. So we sought to evaluate the screening and treatment cascade, and we did this by enrolling women aged 25 to 49 at 5 health facilities spread across the country in Malawi, starting from March of 2022 to September. And the women who we enrolled received HPV testing and VIA screening in the same visit. And those who tested positive in either of the tests, we collected a biopsy, which we sent for histology assessment. And treatment was offered to those who were eligible according to the guidelines of the country. So what we found actually is that first of all, we enrolled just over 4,600 women across the 5 facilities. And in terms of age distribution, it was normally distributed. And we found that just about 53% of our enrolled women were actually women who were living with HIV. And we can see that from March through September, the enrollment period, the enrollment actually was really normal. It was spread across all the months in that period. And going further with the results, we actually find that 68% of our study participants were HPV negative, and 32% were HPV positive, which is quite in tandem with a lot of other studies. And we can see on the right-hand side on the top chart how the HPV test results were spread across the 5 facilities. And in terms of VIA, we were not also surprised with the positivity results, because we find actually that it was 8% positivity rate and 92% were actually negative. And going further, like I said before, for those who tested positive for HPV or VIA, we had to collect a biopsy. And out of the 4,630 enrollments that we had, about 50% of them were actually eligible for a biopsy, and we were able to collect 82% biopsies from 82% of those who were eligible. And for those who were not able to collect the biopsies, a big chunk of them, 55%, they are still waiting for their time to come for the biopsy collection. But it's interesting to note that we had registered 27% of loss to follow-up, and then we had some who became pregnant along the way before the biopsy was actually collected. And the chart on the right-hand side really is just showing also the spread of how we collected the biopsies across the 5 participating facilities. And when we sent the biopsies for histology assessment, you can see actually that in general, in total, we had CIN apologies. This is very sensitive. So we had 89% CIN1 positive, and we had CIN2 as well, giving us about 10%, and we had a small number of, or a small percentage of our participants whose biopsies were actually unsatisfactory. This is really sensitive. Right, and for treatment, am I the only one controlling this? Okay. And good to note as well on the histology results is that much as we had a lot of normal results on the right-hand side chart, but we also registered some percentage of abnormal results in all the 5 participating study facilities. And moving on to treatment, we had 476 women who were eligible for treatment for various reasons. 75% of them were VIA positive, and 19% of them had an abnormal histology result, and we had 6% who were actually eligible for treatment due to clinician discretion. And 74% of those who were actually eligible for treatment actually received the treatment, and a majority of the treatment was by thermal ablation, and we had some who received LIP, and also some proceeded to hysterectomy. So in conclusion, I want to say that we see that scaling up HPV testing has high potential of rapidly identifying more women at risk of developing cancerous, precancerous lesions, and ensuring VIA positive and other high-risk women that they receive timely and appropriate treatment is very critical to reducing mortality from cervical cancer in our setting, and further increasing the capacity of our health facilities to strengthen same-day services in VIA, biopsy collection, and treatment would go a long way to save the lives of many of our women. And establishing a robust patient tracking system plays a key role in linking our women from the screening to biopsy and even further to treatment. And lastly, long turnaround time for histology results remains a big challenge in Malawi. Thank you very much for your attention.
Thank you very much, Mr. Timothy Chereni. I'd like to introduce our last speaker. He is Dr. Berek Johannes Kabalo. He is affiliated with Wolaita Sodo University and will present Can Childhood Stunting and Wasting be Reduced in Drought-Prone Areas in Ethiopia? He conducted a cohort study. Please welcome Dr. Bereket.
Okay, I thank you very much. I'm Dr. Barakat from Ethiopia, and I'm a medical doctor and a lecturer at our university. Today, I'm going to present to you about the initiation of chemotherapy, adjuvant chemotherapy after surgery, and factors affecting it. So this is the most important and has higher public health importance. Sorry for the slide is initially it was a little bit higher, but just I narrowed it. Most of I will focus on. Okay, I will focus on talking. I will spend majority of time on the talking. So this research is on the time to adjuvant chemotherapy and its predictor among postoperative breast cancer patient at Cancer Treatment Center of Awasa University Comprehensive Specialized Hospital. When we see the introduction, according to WHO in 2018, cancer is the second leading cause of deaths globally, accounting for an estimated 9.6 million deaths, or 1/6 in days. And breast cancer incidence is rising and becoming major public health problem in Ethiopia. For your surprise, thank you, the one presenter from Malawi. He has already presented the first one, cervical CA. And breast CA is, by now, it's being increased alarmingly. While I was working in OPD, I encountered a lot of cases of breast CA. By the majority of the cases are being not reported, and mostly this breast CA are diagnosed at its indie stage, at its advanced stage. And people in remote areas, especially in rural area, they came late and they are on the verge of death during diagnosis. So this is the most important public health importance in my country, Ethiopia. I've worked in remote areas while I was a junior general practitioner. I encountered several patients with breast CA. They consider it as infection. Some of them consider it as a normal thing, but they came when the CA metastasized to the lung and to the bone, while complaining cough, when they have shortness of breath and pain at the bone. You know, they don't consider consider it as normal when the lump is in the breast. So this is the most important thing for a patient, and it is the area I want to recommend African CDC and other concerning body to have research on this. It's a very alarming issue. So among the treatment for breast cancer, adjuvant chemotherapy is the most important one that's given after definitive surgical management. So prior to telling about the research, adjuvant chemotherapy is the chemotherapy which is initiated after surgical treatment. So we debride the cancer, and after the removal of the cancer, initially the cancer may have micrometastasis. So as to remove or so as to eliminate this micrometastasis, we initiate chemotherapy. That chemotherapy is ideally supposed to minimize the amount of cancer that has already metastasized. So among the treatment, so breast cancer, adjuvant chemotherapy is the most important thing. And adjuvant chemotherapy decreases the risk of breast cancer mortality. It also reduces the recurrence rate and improves long-term survival. So the time between surgery and the first adjuvant chemotherapy would appear to have an impact on overall survival and disease-free survival in patients with breast cancer. So the selected cutoff point for definition of early and delayed start of adjuvant chemotherapy are differed, but early initiation of adjuvant chemotherapy improves the survival of breast cancer patients. So the surgeon, this mainly relies on the surgeon and the chemotherapy. So the more the early initiation we undertake for chemotherapy, the higher the survival of the patient. So after the surgery, patients should be subjected for adjuvant chemotherapy, which is important for survival as well as for quality of health. So what's the significance of the study is that knowing the time to adjuvant chemotherapy and its predictor in post-operative breast cancer patient can aid in creation of appropriate and tailored adjuvant chemotherapy management strategies. So it can help the community by reducing the risk of death, morbidity, duration of stay in the hospital, and hospital expenditures. So here's our objective: to determine the time and to determine the factors. And the research is conducted on this September in 2022. So the study period is from September 2022 to March 2022, and its institution-based retrospective study was designed, and the source population was cancer patient attending cancer treatment at Awasa University Comprehensive Specialized Hospital. So the results shows that there are around 205 breast cancer patients, and among this, 75.6% were included in the final study. And more than half, around 54.8% of patients were at clinical stage 3 at the time of diagnosis. Imagine, patients, they came to hospital and diagnosis is made in more than 50% of cases when the cancer has already metastasized in advanced stage. And 29% of breast cancer patients were living with additional comorbidities, and 13 of the persons had surgical complication. So in this study, the median time to adjuvant chemotherapy was 69 days. In the research we conducted in our comprehensive specialized hospital, we found that the median time for initiation of chemotherapy after surgery is 69 days. That means a lot of people got delayed adjuvant chemotherapy. And the minimum day is 28 days and the maximum day 157 days. So in this study, the survival time among categories of age, educational status, body mass index, comorbidities, histologic grade, surgical margin, and surgical complication were significantly different. So of the total, 92.5% of patients with comorbidity received adjuvant chemotherapy after 61 days. Regarding surgical complication, 58.3% of patients with surgical complication received adjuvant chemotherapy after 31 to 60 days. So in this, the patients, most of the time in our hospital, in NIRA hospital, when I summarize, the initiation of adjuvant chemotherapy is delayed. Because of the delays, there is decreased survival rate, as well as patients, most of the time, they have, because of the micrometastasis, they have decreased survival rate. So what I recommend, what this research recommends is that after surgery, patients should receive adjuvant chemotherapy as early as possible. Early initiation of adjuvant chemotherapy reduces the mortality and increases the quality of health. Thank you very much.
Please, a big round of applause to all our presenters. Now, for the interest of time, we only have 10 minutes left. I would like to invite the public. Maybe we can gather 3 questions for our presenters. Here at the front, please. Okay.
Hello, good afternoon. My name is Helena from Ghana. So my question actually goes to Mr. Timothy. So I'm actually also currently working on a project in both Ghana and Nigeria where we are aiming to screen 10,000 women using HPV DNA testing. I wanted to find out if you could clarify if all HPV positive also underwent biopsy, or it was just for those who tested VIA positive.
Thank you. Here at the front, please. Please go on.
Thank you very much. My name is Dr. Mos. I am a study physician from Lindubuzima, study conducting institution. So first of all, I want to congratulate all the presenters for the good presentation they have delivered to the audience. So it was very instructive. So I've got many things from those presentations. So as we know, the non-communicable diseases are the diseases which are silent, and they are discovered most of the time at the stages of complications. So I don't want to go far from the topic of which gathered us here. I want to know from an eye of public health system, what do you think? This question is, can be answered by any of the presenters. What do you think that in our countries haven't been done that should be done to reduce the incidence of these diseases, non-communicable diseases, and what should be improved for Africa to get to the point we want to get to. Thank you very much.
Thank you. We can even get the last question at the back, please. Yes, ma'am.
Je vais poser ma question en français. Je m'appelle Vérène. Je travaille à l'hôpital Roi Faisal. Ma question est adressée au docteur Aphrodis de l'Université du Rwanda. Je voudrais demander
Aphrodis, is it okay if she speaks in French? Great, you can go on, please.
Okay. Je voudrais demander, est-ce que l'hypertension serait un facteur aggravant du VIH ou vice-versa? Merci.
Thank you very much. Mr. Timothy, would you please answer to the question, please?
Right, thank you very much for that question which came from Ghana. So I just want to confirm that in this study, like I said, we did HPV testing and VIA screening all in one visit. And for all women who tested HPV positive and VIA positive, we went ahead to collect the biopsies. Thank you very much.
Thank you. Maybe after this, you can go on and answer the question.
Thank you very much for a good comment. So the associated factors to this hypertension among people living with HIV, as you have seen in our presentation, like overweight or being on ART more than 5 years. So this should be addressed by different intervention for reducing hypertension, like measures of maintaining the health diet, where you can maintain your, to lose the weight. So there's another intervention you can apply, like exercising or maintaining your normal weight. So those are interventions you can address to ensure that the hypertension is related to the lifestyle you are already applied, like those issues that can maintain you to increase your age, your height. Thank you very much.
Thank you. And maybe Dr. Tianjane Bula Would you please help us in answering the question regarding how we can reduce the incidence rate of non-communicable diseases? Thank you.
Hello? Yeah. Thank you so much. So as you have seen from my presentation, just to relate on what Timothy presented, you could see that there were some women who were not able to get treatment after screening. So like what we did, we are looking at the screening we are doing with the VIA, whereby women have to come to the hospitals for screening. But now we are bringing the services into the community. And there are times we have services within the hospitals, but if the end users don't know that we have those services, they don't access. So what we need to do is to make sure we are able to sensitize people about the services we have, but also to find strategies whereby we can bring services to the community where most of our people live, and we look at the economical status of these people. They can't come to the hospitals where we have all these services, but if we follow them, give them the services, that will help them a lot. And there's a lot being done even with mental health issues, other non-communicable diseases. There's a lot of awareness which is being done within the country. I'll give an example of Malawi, where now we are also using the social media, the WhatsApp and so on, to share messages with people on where they can access these services. So all this is being done to ensure that people are screened earlier, but also they should understand the need to come to the hospital early for treatment. Thank you.
Please go on, but be quick.
Chair, so I just wanted to add to what Dr. Agatha here has said. So one other thing which I feel we've not done enough in Africa, you can see that from my presentation, the sensitivity or the positivity rate of HPV versus VIA was different. HPV was much higher than VIA. So VIA is a less sensitive screening method as compared to HPV. So if we could introduce or do more in terms of bringing in more sensitive methods in the way we do our screening, this can go a long way in averting the non-communicable diseases in our continent. Thank you.
Thank you very much, and that brings us to the end of this session. I would like you all to congratulate our presenters who has helped us to go through the presentation. Thank you very much. I know that the public has burning questions. Maybe our presenters will be here with us and will be answering your questions. Thank you very much for being with us.
Thank you to all our panelists. We will be transitioning into the closing plenary at 5 o'clock. So we have a few minutes to stretch your legs and get ready for the last session of the day. Thank you.